to share clinical thoughts on total hip replacement in post-TB arthritis.
Good afternoon, everyone. I would like to thank Dr. Ashish sir for providing me opportunity to deliver this talk. So I am going to discuss about the challenges in the tuberculosis of the hip, tubercular arthritis of the hip joint, if it is there. So what are the challenges that may occur? The first is the diagnosis may be wrong, or when we are going to do THA in active disease or healed disease, or previously operated excision arthroplasty, or there are controversies or choices regarding the implant selection. So coming to a case, this patient was 40 years old and he has pain and limping for 4 years, and he was a case of 5 years back. He was suffering from Pott's spine, so he has taken ATT. So clinico-radiological diagnosis was a case of tuberculosis of the hip joint, but ESR and CRP were markedly raised, and we have opened the joint and culture was sent, and it shows the heavy growth of methicillin sensitive Staph aureus. So another case, this was diagnosed as tuberculosis of the hip joint, and ATT was given, and patient was operated for THR was done, and patient presented to us with discharging sinus. We did a debridement of the case, and after thorough clinical examination and profile markers and HLA, it was found to be HLA-B27 positive, and implant removal was done. In this type of implant removal, we should keep in mind that there are chances of proximal femur fracture that may occur, and after 4 months of this surgery, reverse THR was done, and the patient was walking comfortably. So tuberculosis of the hip joint may mimic Perthes disease or ankylosing spondylitis. We should always keep in mind that. So coming to a THA in active disease, when should we operate? So what literature said regarding this? This literature was published by Sindhu et al. He advocated that 3 months of pre-ATT course was taken. After that, THA should be done. And this literature was supported by Kim et al. Like 3 months of ATT course. But this study was done by Wang et al. According to him, 2 weeks of ATT course is more than sufficient to go for a total hip replacement. But this long-term study by Bhosle et al., it showed that 3 months of pre-operative ATT and post-operatively 9 to 12 months of ATT should be given. So coming to a case of active disease, 3 months of ATT has been taken. The patient is uncemented THR was done. Here is the pre-operative walking video of the patient. You can see how the patient walked, and post-operatively patient was comfortable and fine. This is the 1.5 year follow-up. Now coming to THA in healed disease. So here is a challenge of restoring the center of rotation of the head, as there may be acetabuloprotesia or equalizing limb length, as there is flexion deformities may occur. So here is the case of another case. The patient is around 65 to 67 years old. He has suffered from ATT 30 years back when he was 35 years around, and uncemented hip replacement was done. You can see the preoperative walking. He was unable to go to even bathroom also by himself, and here is the post-op follow-up. Another case, here is you can see there is case of acetabuloprotesia, and we have used in this particular case the head as morcellized graft mixed with streptomycin to restore the center of rotation of the head. Here is the pre-op video and post-op video. Just see the confidence of the patient, how walking is. Coming to next case, this patient has suffered from ATT 20 years back, and uncemented total hip replacement was done, and patient is now walking comfortably. Here is the pre and post-operative X-rays and walking video. This case, this young chap was around 20 years. He has suffered from ATT. He has taken ATT 2 years when he was 18 years, and uncemented total hip replacement was done. He came with the shortening and limping and difficulty in walking with painful, and here is the post-op X-ray, post-op video. So coming to THA and previous excision arthroplasty, this case presented to us in September 2021 with painful hip, clinico-radiologically diagnosed tuberculosis of the hip joint. So he was suggested for ATT intake, and he has taken ATT for 3 months, but but pain doesn't subsided, and he was advised for total hip replacement. But patient was financially constrained, so he opted for excision arthroplasty. So excision arthroplasty was done. You can see there is deficient posterior wall. And here, after 2 years, patient again came to us for total hip replacement. So pre-op CT was done. Here was the segmental defect and in the posterior wall. Here was the cavity defect in the anterior wall. And during intraoperatively, we have difficulty in finding the true acetabulum. And we have used the image, and under C-arm guide, we applied the acetabular cup. And here is the reverse hybrid THR was done. So there is controversies regarding implant selection. So we have to keep in the armamentarium like dual mobility cup, multi-hole cup, jumbo cup in case of acetabular protesia. If there is a large defect, or uncemented reverse hybrid or hybrid cup, mace and cage, and recon plate and screws if there was defect in the posterior wall or anterior wall. So the take-home message is effective preoperative ATT followed by THA should be undertaken according to clinical presentation and radiological advancement of the disease. Precise preoperative planning is important for successful THA in these type of patients. Thank you.
Thank you, Vidya Sagar, sir. So now I call upon Dr. Himanshu Swarankar to share a few thoughts on static and dynamic cement spaces in arthroplasty.